শুরু তো আপনি করবেন আজকে।
Okay. Bismillahirrahmanirrahim. Welcome you all to our weekly session, how we practice evidence-based medicine in our everyday life. So we are happy to say that today is the 20th session that we have been running from the beginning of COVID, and we have finished 11 sessions on breast cancer, and now we are running a session on lung cancer. And we are so happy that we have a persistent participation from mid-level and juniors who are our targets, and we could accomplish our mission by sharing our thoughts. And we are also grateful to our foreign faculties who have been supporting from the very beginning. So today our topic is a bit different, is the role of immunotherapy in non-small cell lung cancer. Normally it was supposed to be moderated by Dr. Mustafa Aziz Shumon, but considering the speciality of these topics, so we have redesigned the program that before our main speaker Arman make his presentation, we are planning that Shumon should give an introductory presentation for 10 minutes to give the idea about the basics of immunotherapy. Then Dr. Arman Reza Chowdhury, our main speaker, will talk on our today's topics. So that's why I am doing the temporary makeshift arrangement moderation of the session, rather I would say, which was supposed to be done by Mustafa Aziz Shumon. So as per our tradition, we want to start our session with few words from our president, Professor M.A. Hi, sir. Sir, would you please start the session officially?
Bismillahirrahmanirrahim. I'm happy that we are having our 20th session of actual eCME program. Today we are going to start with a new subject, the immunotherapy of non-small cell lung cancer. Immunotherapy is a very recent development in the field of oncology. And immuno-oncology has developed a new subject also, is immuno-oncology developed, coming up as a new subject. In the beginning of this session, learn about this. So I welcome you all. For the grace of Almighty Allah, progressing nicely. Without any delay, I think we should start immediately.
Thank you, sir. As far as schedule, we were supposed to have two foreign faculty, Dr. Ullas Batra and Dr. John Conebier, but half an hour back, Ullas sent a message for some personal issue. He could not join, but we are expecting John to join with us at any moment. So as I explained at the beginning, that we want to have an introductory presentation from Dr. Mustafa Aziz Shumon on the, he will give a brief outline that how this whole story of immunotherapy evolved and how it works. So I will like to request Dr. Mustafa Aziz Shumon, who is the assistant professor of radiation oncology in Kurmitoro General Hospital, to make his presentation. Dr. Mustafa Aziz Shumon.
Thank you, Kamal Bhai. You have already described why we have makeshift our program today, because the topics immune checkpoint inhibitors is quite new. Though I believe within a couple of years it will be a very emerging subject here in Bangladesh. So we think that to give a basic idea regarding how this what is this immune checkpoints and how these immune checkpoint inhibitors really work, we need to know. So that's why my topic is very basic of immune checkpoint inhibitors. So as you know, there are different type of immunotherapy. Already we have very famous with some vaccines, some adaptive cell therapy. But today I will focus only on immune checkpoint inhibitors. That is the most emerging topics in the immuno-oncology. So go back to in the year 1757 in the battle war field of Polashi. So you know this man, this is Nawab Sirajuddaulah. This slide was taken from Professor Salam sir. I should be really grateful for this interesting slide. You could see this Nawab Sirajuddaulah in the battle in Polashi. So in that battle, Nawab Sirajuddaulah was backed by 65,000 soldiers. In contrast, East India Company, they did have only 3,000 soldiers. So it was supposed that with the 65,000 immunity, Nawab Sirajuddaulah is going to get a flawless victory with a very short time. But all we know that it was not happened in that way. Question is why? Having 65,000 soldiers, in contrast with 3,000 soldiers, he was defeated in that war. Why? Because we all know that his first hand, Mir Jafar, among the 65,000 soldiers, 45,000 soldiers was led by Mir Jafar. And Mir Jafar gave command to his soldiers not to act. So all the 45,000 soldiers stood there and they did not comply the Nawab orders. So ultimately, this defeat was happened. So actually, what happens that the immunity that was that was supposed to be provided by the soldiers, the majority of the immune soldiers did not comply. That's why the defeat was happened. So here in the oncological aspects, the same things happen in case of tumor oncology, because we know that we have a good immunity in our body, so it can fight against the microorganism. But what happened in case of tumor cells? So let's see. So we know that I have already mentioned that we have a very good immune systems that are very capable with the microorganism, but when it comes to the cancer cell, it fails. Why? So actually, in Polashi, Mir Jafar bribed his soldiers. The soldiers, that's why, didn't reply. Here in the cancer cell, when it exposed, it anyhow manages the immune system. So he gives an information to the immune systems, don't kill me. And the immune system of our body acts like Mir Jafar, and they did not reply accordingly. So these things happens really, and let's see in details what is actually happens. So here is a short of immune surveillance. We know that in general we have two types of immunity in our body. That is the innate immunity and the adaptive immunity. And immunity is the first line defense that comes with the neutrophil, macrophage, NK cells, and the adaptive immunity comes with some beta cell and T cells, cytotoxic T cells, and by B cell from the antibody or humoral immunity. So this is in a short in our immune surveillance of our body. So let's think what happens if the immune system really works, if it is a ideal world, if the Polashi world, if all the soldiers really part in the war, what would be really happen in the time? Let's see. If a tumor cells present in the body, it should be taken up with the immature dendritic cells that calls the antigen presenting cells. So after these antigen presenting cells, it should drain the nearby lymph nodes. In the lymph nodes, there you can get a immature lymphocyte, T lymphocyte. So these dendritic cells bind with this immature T cells, and then this binding ultimately initiate a response. These T cells mature, and these mature T cells cause the clonal proliferation. Ultimately, it will kill the tumor cells. So this should be the real world. And if it is really happened, then there will be no question of cancer. But actually, what happened in the body? So how these tumor cells really escape this immunity? You could see, let's think about the T cell. Suppose this is the T cell. You can see there are some receptors over the T cells. And you could see there are some receptors in the right side. On the right side, I marked with red the two receptors, that is CTLA4 and PD1. These receptors are activating receptors. So when the T cell binds with some foreign body like tumor cell or any kind of foreign body antigen presenting cells, these activating receptors, when binds with that specific receptors, it cause a signal to active. That means it initiates the immunity. But when these receptors are bind with the antigen presenting cells, represents the inhibitory response. So don't act with immunity. So why? Actually, why these activating receptors are inhibitory receptors there? These receptors are there to maintain a homeostasis so that our body really don't face overactive immunity, that is the autoimmune disease. So that's why these activating receptors and these inhibitory receptors plays the equilibrium role so that the acute inflammatory response may happen, whether it should not be exaggerated or it should not be less. So if you can see these pictures, the main backbone of any kind of immune response with T cells bind with the MHC class molecules with T cell receptors. And after these receptors, only not these receptor bindings is enough. It needs some co-stimulatory effect. So though these co-stimulatory effect, if this co-stimulatory effect are this positive one, the T cells are activated. If these co-stimulatory cells are these negative ones, the T cells are not activated. So that's why the immunity homeostasis is maintained in our body. So let's come to see. Here you can see, so this is a T cell and this is the antigen parasitic cell. Suppose this is a tumor cell. So in a real world, these tumor cells should be attacked by a T cell, and when these are attacked, this T cell receptor should be bind with the major MHC class molecules, and the co-stimulatory signals, the CD28 and B7 molecules should be attached. And if these two signals are attached, it series a active reaction. So the T cells get active and it attacks the cancer cells. But what really happens? The TCR MHC class molecules attached, but instead of CD28-7 molecules, it attached with CTLA4 molecules. So I have already mentioned the CTLA4 is an inhibitory receptor. So when this B7 bind with the CTLA4-7, instead of activity, it gives an information not to active. So it acts like that Mirzapur and is sitting as an idle. So this B7 and CTLA4 combination plays an important role to make this T cell inactive. Now the question comes, why not these molecules attached with the CD28-7 instead of CTLA4? As because the CTLA4 has more potency to attach this B7 molecules, 20 times more affinity to B7 molecules. That's why in the competition, CD28 fails in competition with the CTLA4. So that's why getting in spite of getting active, it becomes inactive. So this CTLA4 is a site of inactivation of a T cell. This CTLA, you could see these T cell are a naive cell. You could find out in a immature stage in the lymph nodes. But if you can block this CTLA4, if you can block this initiation B7 CTLA4, so this inhibition could not happen. So this is the idea, first idea from this immunotherapy, which was invented by J.P. Allison, and later in the 1918, he was awarded with Nobel. And this is the drugs, that is the ipilimumab, which combines this area, this CTLA4 directed monotherapy. It blocks this CTLA4 so the B7 molecules cannot attach there. So if this is not attached, this B7 attached with CD28, so T cell get active. So how this ipilimumab really works? And come to the PD1 and PDL1. I have already showed that there are only two types of receptor that we really focused in this discussion, the CTLA4 and PDL1. So like the CTLA4, you could see this T cell, here you could get another receptor that is PD1. So in the T cell, the receptor is PD1, and the tumor cell, the receptor is PDL1. This is also a inhibitory receptor. So if this PD1 and PDL1 gets bind, it likes the CTLA4 initiation. It also gives an inhibitory impulse to T cell, not to active. So this PD1 and PDL1 are another culprits for this inactivity of this T cell. So if we can block this binding like CTLA4 that can be blocked by ipilimumab, if we can block this PD1 by any kind of immune checkpoint inhibitors, we can block this inactivity of these T cells. So as these are inhibitors, these are called the checkpoints. So CTLA4 or PD1 are called these checkpoints because they are allowed to check this immune initiation. So if we are going to inhibit these checkpoints, that's why the name of the drugs are checkpoint inhibitors. So we are here inhibit the checkpoints. That's the role of the checkpoint inhibitors. So CTLA4 blocked by ipilimumab and PD1 blocked by the another nivolumab, pembrolizumab. Let's see. So this is a very wonderful picture. I am grateful to Dr. A.F.M. Kamaluddin. He really give me these slides. These slides give you an idea. So the main combination of major MHC class molecules to T cell receptor is like the initiation. It is like the driving car key. But CD20 and B7 is like the acceleration. So if T cell binds with CD28 with B7 molecules, it causes acceleration, it initiates activity of the immunity. But instead of this CD28 B7 complex combination, if the combination happens with the CTLA4 and B7 or PD1 and PD, it's like pressing the brake. So these are the drugs that act like brake. So come to this point, you could see that this is the drugs, that is the ipilimumab. Let's think about this is a tumor cell and this is a T cell. And here you can see that the MHC class molecules is bind with the T cell receptor. There's a binding is done. So now there should be a response that the B7 CD28 molecules should bind, and it is also bind. But if this is bind with CTLA4 with B7, there would be no activity. So we need to block this initiation. And this initiation, you could see this rate. This is the ipilimumab drugs. This blocks this CTLA4A. So there would be no combination this B7 to CTLA4. So there is no inhibition. So this B7 CD8 combination, according to MHC and TCR, ultimately this T cell activation occurs. So this is the mechanism of ipilimumab, the first immune checkpoint inhibitors. Come to the very famous nivolumab and pembrolizumab. You could see that considering the T cell, you could see that these T cell receptors bind with major histocomplex complex. And here this PD1 is bind with PDL1. So we need to block this area because if this bind with PD1 and PDL1 is this combination occurs, there will be inhibition. So we need to block this area like this area. So this is the drugs that blocks this PD1. So this immunotherapy, monoclonal antibody targeted this PD1 receptor. This immunotherapy blocks this area. So this PDL1 and PD1 combination can't happen. Ultimately, no inhibition, so activation of the T cell. So these are the drugs that act on this area. These drugs are nivolumab, pembrolizumab. So from this point, we could get an understanding that the CTLA4 works mainly this area, and nivolumab, pembrolizumab works in this area. So there are nivolumab, there are pembrolizumab, there are ipilimumab, but we have also atezolizumab and durvalumab. How it acts? So you can see the same type of picture, the T cell over there, and this is the cancer cell. So I have mentioned two receptors, that is PD1. Always remember the PD1 is on the T cell and PDL1 is the antigen present cell. So nivolumab, pembrolizumab blocks the PD1 receptor. So they are anti-PD1 drugs. And PDL1 that presents on the antigen presenting cells, it is blocked by the atezolizumab, durvalumab. The mechanism of action is more or less same. They are monoclonal antibody. This antibody acts on the anti-PDA that presents on the T cell, and this antibody works on the PDL1 that's present on the antigen presenting cells. So actually, they blocks this receptor combination PD1, PDL1, and they makes the activity of the T cells. So here is the just graphical presentation of my speech. You could see what happens really. If this PDL1, PD1 binding combination occurs, they send a inhibition. Ultimately, T cell become inactive. But if you can block this PDL1, PD1 combination either by PDL1 blockage like atezolizumab or durvalumab, or if you can block this PD1 by nivolumab or pembrolizumab, we could active this T cell. So if there is if there is inhibition, tumor cell grow. If there is T cell activation, tumor cell will die. So that is the mechanism of this immune checkpoint inhibitors. So that's all. But after getting this, getting through this immuno-oncology, I could find this is just the tip of iceberg. So there is a number of things we need to know because the immunotherapy is very new to us. Its mechanism of action, its duration of action, its toxicity, its biomarkers, its what we could say, its response evaluation, that is the iRECIST, is quite different from that. We are very familiar with our CT scan evaluation. That is not very familiar. So I think we should go through some series of lectures regarding immuno-oncology. If we all consider these things, I think we should need another 2 or 3 lectures on this immuno-oncology. Thank you very much.
Thank you, Shuman. First of all, I should congratulate you because this assignment was given to you only 24 hours back. And I had trust on you, and you have done justice to my trust that you have made a wonderful presentation. I'm sure that now all of us have a basic idea that how this wonderful immunotherapy works. Thanks, John, for joining, sacrificing your holiday. I'm sure you enjoyed the cycle bike club, and then you joined.
Thank you, Kamal.
Okay, John. So I think we go for our next speaker, and thereafter we go to question answer session together. Just for information that we made some change in our design because the daytime is very short now, so we will be trying to finish our program in 1 hour, number one. Number two, from next week, we will not have our case discussion, but rather we will have a debate. So next week we will have a debate, and the debate will be done by, as usual, our brilliant student debaters. So now I request Dr. Arman Reza Chowdhury, who is the consultant of oncology in Delta Hospital, to make his presentation. Arman is a very brilliant oncologist and very active in national and international platform. So we hope that we will be enjoying his presentation. Arman.
Thank you. Okay, thank you so much, Dr. F.M. Kamaluddin, for your nice introduction. And thank you, Oncology Club, for giving me the opportunity to say here, to tell about immuno-oncology in case of non-small cell lung cancer. At first, I should say that I practically, I don't have any experience by to use this molecule in my non-small cell lung cancer patients. But I am privileged that Dr. F.M. Kamaluddin and Dr. Mustafa Aziz Shuman asked me to make the presentation, and it will very much, definitely it was very much helpful for me because I go through the publications, papers, and learn many things. Today I'm just sharing my learning with you. So my topic is use of immune checkpoint inhibitor in non-small cell lung cancer. Am I audible clearly?
Yes, you are audible. Please.
Okay. So this is the current treatment overview of advanced or metastatic non-small cell lung cancer. That is initially we use actually chemotherapy as a standard of care, and it is the backbone of therapy in case of advanced or metastatic non-small cell lung cancer. Then the TKI, that is tyrosine kinase inhibitor, come with either patient have EGFR, AL, CROS1, etc. positive, and then or alterations. Then we use this, and it gives some improvement of the outcome in patients with mutations. And now the immune checkpoints, obviously, Dr. Shuman has very elaborately, and it was a fantastic presentation by him about the basics of how the drugs works. So after that, already Dr. Shuman already mentioned this cartoon, and So how it works? Historically, I have already mentioned that we treat tumor cells with chemotherapy or radiotherapy or target therapy, and the new paradigm is immunotherapy. So how it acts? Already mentioned that we trained our immune system to attack the cancer cells, and our immune system have two types of cells. That is mainly that is APC, that is antigen presenting cell, and T cell. So antigen presenting cell, these cells looking for the cancer and other diseases, and the T cell, it in our body, it acts as a soldier of immune system. So what happens? The antigen presenting cell, it start the immune response, and the T cell, it works, that is it kill the foreign body or the cancer cell. So but the cancer is complex, and already Dr. Shuman mentioned that it has some checkpoint, that is PD1 or PDL1, and this PD1 and PDL1 bind and make the complex and tells the T cell, like this cat, please don't kill me. So the T cell are switched off before killing is done. But if we can inhibit the binding of PD1 and PDL1 by using the ICI, that is immune checkpoint inhibitor, that will prevent T cell from being switched off. And so that what will happen? The T cell can continue its job and the tumor can be eradicated by this immune system. So this is the bindings PD1 and PDL1, and if we block this binding, then we can achieve our desired result. And the benefit of immunotherapy don't stop when the treatment is ends. That is the fantastic idea, because immunotherapy helps immune system to remember the cancer, so the T cell can quickly target the cancer when it returns. So patient with 2 consecutive years of treatment can benefit for a long period of time after the withdrawal of the immunotherapy drug. But also with the good news, there is a sad news that only 25 to 30% of the patient of the tumor use this PD1 PD-L1 pathway to suppress the immune system, whereas the tumor use the other molecular pathways or mechanisms to escape the immune response, which we currently know very little about this. So this is the sad news. And this slide, actually, this is the development or evolution of treatment of non-small cell lung cancer with chemotherapy, with TKI, and with immunotherapy. And here we can see that in 2015, the first approved immune checkpoint inhibitor as a second line, and in 2016, the approved immune checkpoint inhibitor in first line. So what are the topics of my discussion? Now, first of all, the immune checkpoint inhibitor in second line setting and relevant paper, immune checkpoint inhibitor in first line setting, ICI in combination with chemotherapy, and use of ICI in not only in the metastatic or advanced disease, but also in the locally advanced lung cancer. And lastly, 2020 updates of immuno-oncology in lung cancer. So at first, ICI in second line setting. So there are 4 papers: the Checkmate 017, Checkmate 057, Keynote 010, and OAK study. And in all these papers, or all this study, immune checkpoint inhibitor was compared with docetaxel in case of stage 3 or stage 3B or stage 4 with platinum prior exposure lung cancer patients. And in this slide, we can see the results of all, because in Checkmate 017, nivolumab is compared with docetaxel in squamous histology, and in Checkmate 057, nivolumab was compared with docetaxel in non-squamous setting. In Keynote 010, pembrolizumab versus docetaxel was compared, and in OAK study, atezolizumab and docetaxel was compared. And here, in all setting, we can see that with the use of immune checkpoint inhibitor, it gives better results in terms of overall survival. And after that, in AACR annual meeting 2017, there was a summary, like treatment with the immune checkpoint inhibitor, that is nivolumab, yielded durable responses in some patients with advanced non-small cell lung cancer with a 5-year survival rate of 16%. That is actually huge. The 5-year survival 16% with the use of immunotherapy molecule, and the toxicity is mostly tolerable. So that was the basic or backbone for immuno-oncology in non-small cell lung cancer, or immunotherapy in non-small cell lung cancer in second line setting. And now the first line setting. This is Keynote 024 study. It's a phase 3 study where the pembrolizumab is compared with platinum doublet chemotherapy in case of advanced metastatic non-small cell lung cancer, where PD-L1 expression were more than or equal to 50% of the patients, and no patient activating EGFR or mutation or ALK translocation. And the primary endpoint was progression-free survival, and the secondary endpoint was objective response rate and overall survival. And here we can see, regarding the progression-free survival with the use of pembrolizumab, it was 10.3 months, and with chemotherapy it was 6 months. That is statistically significant result. And regarding objective response rate, it gives better result with pembrolizumab. During this study, the overall survival data was not reached, but the updated analysis of this Keynote 024 was also published in Journal of Clinical Oncology in 2019. And here we can see that with the use of pembrolizumab in metastatic advanced non-small cell lung cancer with PD-L1 expression more than or equal to 50%, it gives median overall survival of 30 months, whereas with chemotherapy it was 14.2 months. And if we want to see the forest plot, we can see that in all terms it gives better result in pembrolizumab arm. So in conclusion, pembrolizumab monotherapy significantly improved the progression-free survival and overall survival, as well as had a better safety profile versus platinum-based chemotherapy in previously untreated metastatic non-small cell lung cancer, with no sensitizing EGFR ALK alterations and with PD-L1 expression more than or equal to 50%. Now another paper, that is Keynote 042, and you can hopefully anyone can recognize this person. He is Mr. Dr. Tony Mock. He is the author of lung cancer, especially the targeted therapy and immunotherapy. So the Keynote 042, this study was comparison between the pembrolizumab versus platinum-based chemotherapy in case of metastatic or locally advanced or metastatic non-small cell lung cancer, where the PD-L1 expression was more than or equal to 1%, and no EGFR or ALK alterations. Performance status was good, and no unstable or untreated CNS metastasis. So the primary endpoint was overall survival in PD-L1 expression more than or equal to 50%, 20%, and 1% in overall populations. And the secondary endpoints were PFS and ORR in the same populations. So here we can see, regarding overall survival data, the median overall survival with this pembrolizumab is 16.7 months, whereas with chemotherapy it was 12.1 months. And it was in case of more than or equal to 1% PD-L1 expression. And with 50% and with 20%, we can see that all give some better results with this pembrolizumab. And if you want to see this forest plot, here we can see that in all terms, it favors the pembrolizumab in case of more than or equal to 1% PD-L1 expression. So regarding PFS, the PFS was 5.4 months. Median PFS was 5.4 months with pembrolizumab, but with chemotherapy it gives some better. It gives 6.5 months, and with chemotherapy. And regarding objective response rate, we can see this blue bar. These are for the pembrolizumab arm. So obviously this gives better objective response. And with the if you want to see the adverse events of this pembrolizumab versus the chemotherapy, and here we can see that in all except the hypothyroidism, in all mentioned toxicities, the toxicity is lower with immune checkpoint inhibitor. So the conclusion of that very famous study, Keynote 042, that in patient with advanced or metastatic non-small cell lung cancer without EGFR ALK alterations and with PD-L1 expression more than or equal to 1%, first-line pembrolizumab significantly improved the overall survival versus platinum-based chemotherapy. And there was no significant improvement in progression-free survival with this pembrolizumab. Already I have mentioned. And toxicity is well tolerated, and the safety profile is very good. So it can be considered as a first-line treatment options for all PD-L1 positive cancers. Now, checkmate 026. It was the study between the study that is the use of first-line nivolumab in stage 4 or recurrent non-small cell lung cancer, published in New England Journal of Medicine in 2017. And here the chemotherapy is compared with nivolumab in stage 4 or recurrent non-small cell lung cancer. Primary endpoint progression-free survival, and secondary endpoint also the progression-free survival in 1% or more PD-L1 expression, overall objective response rate, and overall survival. And we can see the results here. The progression-free survival with nivolumab, it was 4.2 months, and median progression-free survival with chemotherapy, it was 5.9 months. And if you want to see the overall survival with nivolumab, it was 14.4 months, and with chemotherapy, it was 13.2 months. The difference is not so high. So actually, it was a negative trial, and nivolumab was not associated with significantly longer progression-free survival than chemotherapy among the patient with previously untreated stage 4 or recurrent non-small cell lung cancer with a PD-L1 expression less than or with a PD-L1 expression level more than 5% or more. And the overall survival data was similar between the two groups. So now already we discussed about the use of ICI, that is immune checkpoint inhibitor, in as a monotherapy in case of metastatic or recurrent non-small cell lung cancer or advanced non-small cell lung cancer. Now the time for combination with chemotherapy. And this is a paper, it was known as Keynote 407, where the pembrolizumab plus chemotherapy was used. Here you can see that it was a randomized phase 3 trial where patient with untreated stage 4 squamous non-small cell lung cancer, good performance status, were randomized to pembrolizumab plus carboplatin plus paclitaxel or nab-paclitaxel versus carboplatin and paclitaxel plus nab-paclitaxel. And the primary endpoint was progression-free survival, and the secondary endpoint was overall response rate and safety profile. So here we can see that with the use of combination, that is chemo-immuno combination, the overall survival was 15.9 months, and with placebo, that is only with chemotherapy, it was 11.3 months, which was statistically significant. And regarding progression-free survival, the chemoimmunotherapy gives 6.4 months progression-free survival, but only chemotherapy, it gives 4.8 months, which is also statistically significant. And regarding the hazard ratio, regarding the forest plot, we can see that in all terms, it gives better, or it gives favorable opinion in chemoimmunotherapy. So the conclusion of Keynote 407, in patient with previously untreated metastatic squamous non-small cell lung cancer, the addition of pembrolizumab to chemotherapy with carboplatin plus paclitaxel or nab-paclitaxel resulted in significantly longer overall survival and progression-free survival than chemotherapy alone. Another paper, that is Keynote 189, where the chemotherapy is combined with the pembrolizumab in one arms, and another arms only chemotherapy in case of non-squamous non-small cell lung cancer. And here, if we want to see the result, the progression-free survival in intention to treat patients, here we can see that the median progression-free survival was 8.8 months with this chemoimmunotherapy and 4.9 months with this chemotherapy alone. And regarding overall survival, it was not reached the median overall survival, but the result is giving better. And in Keynote 189, the overall survival by PD-L1 expression, in case of less than 1% PD-L1 expression, it gives better results. With 1 to 49%, it gives better results, and with more than 50%, it also gives better result. And regarding PFS, in PFS, we can see here that with chemoimmunotherapy, it gives better results. So in patient with previously untreated metastatic non-squamous non-small cell lung cancer without EGFR or ALK mutations, the addition of pembrolizumab to standard chemotherapy of pemetrexed and platinum-based drug resulted in significantly longer overall survival and progression-free survival than chemotherapy alone. Another paper, that is Empower 150. Here the atezolizumab is compared as a 3-arm study. Here in case of stage 4 or recurrent metastatic non-squamous non-small cell lung cancer, chemotherapy naive patients. Here the atezolizumab is compared with atezolizumab is added with carboplatin and paclitaxel, and atezolizumab, carboplatin, paclitaxel, and bevacizumab, and paclitaxel, carboplatin, and bevacizumab were compared. And if we want to see the progression-free survival with the addition of this atezolizumab with paclitaxel, carboplatin, and with the addition of bevacizumab, it gives a better outcome. And regarding overall survival, the data is almost similar. So progression-free survival was also longer in the atezolizumab, paclitaxel, carboplatin, and bevacizumab arm than in bevacizumab, carboplatin, and paclitaxel arm in entire intention to treat population. And the patient with low and negative PD-L1 expression, it was the result was found. So the addition of atezolizumab to bevacizumab plus chemotherapy significantly improved the progression-free survival and overall survival among patients with metastatic non-squamous non-small cell lung cancer, regardless of the PD-L1 expression and EGFR ALK genetic alteration status. Now, in case of locally advanced disease, the very famous Pacific trial where durvalumab was used in case of patient with locally advanced, that is unresectable stage 3 non-small cell lung cancer. And with the use of durvalumab, if we want to see the overall survival data in 2 years, it was 66.3% with durvalumab, and it was 55.6% with this placebo. So durvalumab significantly prolonged the overall survival as compared with the placebo. And regarding median time to death or distant metastasis, with the use of durvalumab, it increased, that is 28.3 months. Median time to death or distant metastasis, it increased with the use of durvalumab. This is some summary of some important question in non-small cell lung cancer immunotherapy, like what should be the performance status. And here we can see that the in case of performance status, ECOG performance status more than or equal to 2, less response and reduced survival duration. So immune checkpoint inhibitor cannot be endorsed in this population without caution. Elderly age, immune checkpoint inhibitor can be given to the older patients. Autoimmune disorder, immune checkpoint inhibitor can be given to patients with autoimmune disorders, especially those without immunosuppressive medications, but at increased risk of immune-related adverse events. So we should be careful. Regarding brain metastasis, immune checkpoint inhibitor can be given to the patient with asymptomatic brain metastasis in non-eloquent areas with close imaging follow-up. Regarding driver mutation, immune checkpoint inhibitor are only option in driver mutated patients when the other treatment lines are exhausted. So now, lastly, some slides on the non-small cell lung cancer immuno-oncology year in review 2020. I just go first with this. It is a paper published in Lancet Oncology in this year, and with the use of atezolizumab with carboplatin and nab-paclitaxel, they found very good major pathological response when used in neoadjuvant setting in case of resectable non-small cell lung cancer. Another paper, Empower 110, published in Journal of Clinical Oncology, and the conclusion of that paper, atezolizumab was better tolerated than chemotherapy, and the immune-mediated adverse events were generally low grade. Another paper, Checkmate 227, which was also published in this year, the first-line treatment of nivolumab plus ipilimumab resulted in a longer duration of overall survival than did chemotherapy in patients with non-small cell lung cancer, independent of the PD-L1 expression levels. That is very important. Another paper, Checkmate 9LA study, where nivolumab, ipilimumab plus chemotherapy versus chemotherapy was compared, and the conclusion of that paper was nivolumab and ipilimumab plus chemotherapy should be considered as a potential first-line treatment options for patients with advanced non-small cell lung cancer. CityScape, another paper, the first-line use of tiragolumab and atezolizumab yielded clinically meaningful improvement in patients with PD-L1 positive metastatic non-small cell lung cancer compared to the placebo plus atezolizumab. So these were the year in review for this 2020, and the take-home messages from my presentation is, in conclusion, immunotherapy with anti-PD-1 or PD-L1 antibodies profoundly modified our vision in treating locally advanced and metastatic non-small cell lung cancer, and it will probably modify the treatment of earlier disease non-small cell lung cancer. Currently, immunotherapy alone, like pembrolizumab, or in combination with chemotherapy, like pembro or atezo, is standard of care for first-line therapy of stage 4 non-small cell lung cancer, while new immunotherapy combinations such as nivo-ipi may be another option in near future. Durvalumab is now the first immunotherapy validated for adjuvant treatment in case of stage 3 non-small cell lung cancer, non-progressing after concomitant chemoradiotherapy. And many questions already also remain unresolved and should be clarified in the near future. So this is the last slide of my presentation, and we are actually in a COVID situation, and we are awaiting for leaving up our mask as soon as possible. I hope so. Thank you for your patient sharing. Thank you all.
Thank you, Arman. It was a detailed presentation. I will say that you have covered everything. I just want to add only one small point, that in your slide you say that AAS year 2017, they have shown in phase 1 that there is 16% response with pembrolizumab for 5 years overall, so 16%. It was compared to the only chemotherapy 6%. That was the main catch, because with only chemotherapy, the 5-year survival is only 6%, but the immunotherapy is showing 16%. So there is a benefit of 10%. That was the main driving force of bringing it up. So I think, as you mentioned at the end, that there are many questions, remain and many questions is evolving, and whole the world is learning how to deal with immune checkpoint inhibitors. And for our country, we are at the very beginning stage. So before going to the question and answer, I will ask John to say that what is, I mean, very briefly, you can say that what is your, I mean, common practice? I mean, how often you are using the immune checkpoint inhibitor? Because to me, when NICE guideline approves something, that is the most rational, because other guideline has many issues. But when something is approved by NICE, we need to understand that there must be very strong validation, otherwise you don't go for it. So how you people are handling it?
So really nice talks this morning. Thank you for those. So they've revolutionized really what we're doing in lung cancer. And I'd say that almost all patients now receive an immune checkpoint inhibitor in a line of therapy, and actually most patients currently in the first line setting. So in terms of the current landscape in lung cancer, so I know we haven't really talked about small cell, but we've got it as a nice approved option in first line small cell with combination chemotherapy. In the non-small cell setting, if we ignore COVID-19 pandemic, essentially it's very much driven by PD-L1 expression. So anyone who's over 50% is permitted access to single agent first line pembrolizumab. Anyone with less than 50% expression in combination with chemotherapy, and the chemotherapy regimen is dependent on the histological subtype. Interestingly, in the UK, we're not restricted to single agent immunotherapy in over 50% expressors. So, for instance, I will use combo immunotherapy even in high expressors if they've got large bulk volume disease, because I feel the chemotherapy offers a more rapid response to the tumor volume. And in fact, if they have a really good response to the chemo, then I'll de-escalate their therapy back down to single agent immunotherapy. The COVID-19 pandemic has changed things slightly. So NICE has made some decisions in terms of treatments to reduce the risk of immune suppression, and therefore the risk of COVID and unwanted outcomes. So they've allowed us to use single agent immunotherapy in patients with a PD-L1 expression of 1 to 49% without chemo, which is quite, so that will go, no doubt, once the pandemic's over. Because I'm not convinced, you know, and I warn my patients now that without the addition of the chemotherapy, I do believe that you're reducing the potential efficacy of that combination. And I sometimes feel that giving single agent Pembro for a PD-L1 expression of 3%, you know, I prefer to give them the chemo and advise them on the risks rather than, you know, waste those resources, I feel. And then in the second line, what we've seen over the last 2 years is, as you can imagine, a huge reduction in the amount of immunotherapy we use second line. So we used to use a lot of atezolizumab as our second line therapy in patients post chemo. And of course, these patients now have all received chemo immunotherapy first line. So that's dropped dramatically. The other thing to say is the NICE approvals are predicated on 2 years of therapy. So there is a time restriction on the length they can receive it. And of course, outside of the NHS, there is no restriction. So I've got patients who have gone beyond 2 years with these drugs, which you've got the cumulative financial toxicity then. The last thing I'd say is it does pose a problem. So I have had patients who've had a fantastic response to their immunotherapy, have reached 2 years and have continued on complete response, have then had to stop immunotherapy. And of course, then after 6 to 8 months, you begin to see progression of their disease off immunotherapy. And in the NHS, there isn't a mechanism currently to bring those patients back into immunotherapy. So that's a problem, you know, albeit a small one, but a very important one.
Thanks, John. I think you have given a wonderful insight that immunotherapy is a wonderful drug, but may not be the only solution for all patients as a single agent, except in a special condition of more than 50%, as you mentioned. As I agree with you that because it pick up very slowly, it is not like the TKI. TKI has a osimertinib 80% response. It is never 80%. It will never be 80%. So always a combo will be better than a single agent, as you mentioned, definitely. And it will be never a single agent as a first line, maybe, except exceptional case. And escalation and de-escalation, both is a challenge in immunotherapy. And I think the last portion that you mentioned is the most challenging part, that at the end of 2 years, having a wonderful response, once we stop and it is coming back, and we don't know, intermittent challenging, whether it will be helpful or not. So this is a big question, that what is the duration? The chat box, there is a question, what is the duration? The answer is actually, we don't know, probably. So yes, for adjuvant, they have recommended 2 years, but for metastatic, I think nobody knows. So now we go to our question answer session. Dr. Riyad, you have a question, one already answered. You can ask another question, Dr. Riyad.
Thank you, sir, for nice presentation. So my question is, what is the criteria to select either atezolizumab or pembrolizumab? How we can select this? And again, another question, which is an old one, but is there any role of steroid or any contraindication of steroid when we are treating with immune checkpoint inhibitor?
Okay. Thank you, Riyad, for your question. First of all, already from the presentation of Dr. Mustafa Aziz Shuman Bhai, you have already known that the pembrolizumab is a PD-1 blocker.
Yes.
And the atezolizumab, it is a PD-L1 blocker.
Yes.
And there are so many papers, sometimes they use that PD-1 blocker and sometimes they use PD-L1 blocker in the treatment of non-small cell lung cancer. But the selection criteria, actually, I think Dr. F.M. Kamaluddin or Dr. John may help me that actually what may be the selecting criteria. Like in case of like TKI, we use
Arman, it is totally physician's choice.
yeah,
It
yeah.
is there is no selection criteria.
I'm also thinking so, but I'm just want to know that is there any expression level wise selection criteria regarding non-small cell lung cancer?
No, no.
John.
Yeah, so in the first line setting, selection for single agent immunotherapy is based on PD-L1 expression, and so the studies who got there first really were the keynote study. So that's really the use of pembrolizumab, and as a consequence, pembrolizumab has dominated the first line setting. Atezolizumab came along in the second line setting with their OAK data. And what was very interesting about that is it took all comers in terms of expression, PD-L1 0, greater than 1, greater than 50, and demonstrated that second line atezolizumab post chemotherapy seemed to offer benefit against docetaxel irrespective of PD-L1 expression. And they validated that data using the drug-specific test kits. So they used the Roche and the they used the MSD and BMS kits, and confirmed that even using those PD-L1 test kits, it was still validated that atezo works in second line, no matter what your PD-L1 expression. So in our practice in my center, we made the conscious decision to offer atezolizumab as our standard second line treatment because we didn't have to worry about the PD-L1 expression. But when it comes to the patient presenting initially, it is predicated on their PD-L1 expression for whether or not they can have single agent therapy or should be recommended combination treatment. There are a few caveats to that. So in the context of patients with oncogene driven tumors, so EGFR, once they've become refractory or they're no longer, or they're unable to tolerate TKI therapy, the data would seem to support the IMpower 150 regimen, which is atezolizumab plus Avastin plus carbotaxel, and it as their first line immune-based combination treatment, because it seemed to show increased efficacy in that subpopulation of patients. So we don't normally ever offer single agent immune therapy to patients with oncogene driven tumors because they don't seem to respond without the addition of those other either chemotherapy or chemotherapy plus antivascular agents. And I hope, and I think there's a question about steroids. So really, we do avoid long-term steroid use in patients receiving these agents. As you can imagine, we routinely use steroids for certain chemotherapy combinations. A good example is the dexamethasone patients receive pre, during, and shortly after pemetrexed, and also the use of dexamethasone when patients receive Taxol, so for instance in the squamous cell or IMpower 150 setting. So we haven't adjusted our protocols to remove those steroids. It does seem to be fine for patients to have those short bursts of steroids for the purposes of allergic reaction suppression or for anti-nausea medications. Ultimately, though, if patients are on greater than 10 milligrams of prednisolone as a chronic steroid dose, if they're on more than that, we do try and sort of bring them below that level so that we can give them immunotherapies. We do worry it will impair its ability to work. Hope that answers the questions.
Thanks, John. So what John was trying to mention, that immunotherapy is a wonderful drug. Unfortunately, it doesn't work good when there is a mutation like EGFR, ALK, or ROS. So that is the group where it doesn't work. But this 150 trial have shown that when it fails on this mutated drug or when they cannot tolerate, their immunotherapy with bevacizumab, with chemotherapy, this combo is showing some hope. So this is the way that my escalation of drug, we are overcoming some of the challenges. And as to Riyadh, I can tell you another thing, that to select the drug, as Mustafa Aziz was telling, that is physician's choice. So when you encounter a situation, you match your situation with the trial that has recommended the drug. So that which trial inclusion criteria is matching with your situation. And that will be helpful for you to select the drug. And then if you have two drugs, then you choose which one you take. So that is actually the real life evidence-based practice. So now
Kamal bhai, I have
yes,
a question.
Yes, please.
When we switch from TKI to immunotherapy, in some situation that John mentioned earlier, so what should be the ideal gap between these two? Can we offer this immunotherapy just after this end of this TKI therapy, or there should be a gap, time gap?
In the study, there is no time gap mentioned. John, is there any time gap required to switch?
Yeah, you should leave a gap to allow a washout period for the osimertinib or fatinib, whichever they're on, because there is an increased risk of pneumonitis once they. So you don't want them to stop the day before and then start their immunotherapy. You should really have a week's gap.
Only a week. I mean, not a very big significant gap is required. Okay. So there is a question from Orunangshu. Orunangshu.
Yes, Kamal bhai.
Yes, please ask your question.
So my question is there any role of the concurrent use of immunotherapy and lung cancer? Mostly we know in a stage 3B, concurrent chemoradiation is a very good option, but still overall survival and progression survival is not that good. So can we, is there any trial ongoing or any idea about integrating the immunotherapy with the radiotherapy? So this is my question.
Arman, would you like to take?
Yes, the trial is going on, but I cannot explain the details. I think John can give better answer.
So you've got the Pacific trial, which was AstraZeneca's initial study in unresectable stage 3 disease, looking at adjuvant durvalumab for 1 year post completion of concurrent chemoradiotherapy, and it's demonstrated a significant improvement in overall survival and reduction in distant metastatic disease. So on the back of that study, there's now many studies looking at the role of immunotherapy, either in combination or sequenced after radiotherapy. So a good example, we're taking part in the Pacific 4 trial, which is in early lung cancer, patients receiving stereotactic radiotherapy. So for those patients, they were receiving stereotactic radiotherapy followed by 2 years of either placebo or adjuvant durvalumab. And in fact, in the last 2 months, they've adjusted the study because they now feel that concurrent immunotherapy with the SABR is no longer seen to be toxic. So they've adjusted it to allow that. And in fact, we now have studies in small cell looking at combination radiotherapy, immunotherapy, and PARP inhibitors. I know MSD are doing comparative studies to those of AstraZeneca, so both in SABR and in stage 3 disease. What's interesting, though, is there does seem to be a confidence now that giving immunotherapy concurrently with radiotherapy is seen as safe and doesn't seem to lead to increased rates of pneumonitis, and therefore these trials have been designed to confirm those beliefs. So there's lots of studies going on.
We can see that from metastatic, it came to adjuvant, and as it moves, it has moved to neoadjuvant. And surprisingly, all the concurrent trial with immunotherapy and TKI came not with conventional, first started with SABR. And once they found it safe with SABR, then they are trying to move the conventional. That is quite interesting for me, but that is the quite trend that we can see, that all the newer molecules, they are always trying with the SABR. TKI, they have hardly tried with conventional, but they are doing many trials with SABR. So that is the interesting part of the observation. So as I was mentioning that we want to be very restrictive on the time frame. So even we may have some more question. I want to stop the question now. So can we go to the quiz? Samir, put the quiz on the chat box, and during the quiz, if you want to discuss, we can have this 5 minutes time to discuss. If somebody is ready to discuss sacrificing the quiz participation, they are welcome. Okay, Samir, put the link on the chat box. It is given. So,
Dr. John, I have a question to you. That
yes,
as initially I have mentioned that I don't have any experience of using immune checkpoint inhibitor in case of lung cancer. So what are the toxicities actually you face in your day-to-day practice commonly in treating this with this immune checkpoint inhibitor, and how you will manage those toxicities?
So I'd say when you first begin to use these drugs, so in the setting of single agent therapy, I tell my patients, the majority, so it's only really a handful of patients who'll get a serious immune-related toxicity. The majority of the patients I treat tolerate it really well, maybe with fatigue, mild diarrhea, possibly a rash. So it's that sort of 1 in 10 patient who develops a severe toxicity. And because they can be so varied, I advise my patients, each day they wake up in bed to start from their toes, work up to their nose, and really ask themselves, do things feel as they did the day before? Because some of these side effects can be very subtle and can be overlooked. And what's undoubtedly important is the sooner we pick these side effects up and we introduce steroids, be it oral or IV, depending on the grade and severity, the quicker we are in terms of reversing those unwanted side effects. So I've got a lady very recently who had her first round of pemetrexed, pembrolizumab and carboplatin, and in fact only 2 weeks into cycle 1, she complained of chest pain and she developed an immune-induced cardiomyositis with a troponin level of over 15,000. So she went to our ICU, received methylprednisolone, and is now on a weaning dose of steroids and seems, touch wood, to be okay. But even after that 1 cycle, her initial CT scan has shown a response in her lung tumor and bone metastases. The obvious concern is that her echocardiogram at the time showed a significant drop in her left ventricular ejection fraction. So we're obviously all very hopeful that that will recover. But, even within 14 days, you can develop these side effects, which if you're not being observant, you can miss, and these patients can potentially miss the boat. So it's really important that you take the patient's most seemingly irrelevant symptoms seriously, because it can be an early indicator that something is not quite right. But again, I reinforce the fact that it's only a handful of these patients that have these big problems, but it's important to pick them up.
Thank you.
Thanks, John. I liked your comment to pick it early, because I have a patient running with durvalumab, and he's a doctor. But the problem is, because there is no significant side effect, even the patient is very reluctant to look for anything and take it granted that nothing will happen. But as you mentioned, it may happen anytime, and it very quickly may become grave. So I think it's a good caution for both the patients and the doctors that even the side effect number is very less, but it should be picked up early, because we can manage with the steroid very easily. But if it is late, it may be devastating. And one this type of thing, we may make a break for a beginner like us, because we have started with a very enthusiasm, and one such thing may halt the speed of our enthusiasm. So I think that is a very nice suggestion that you have given, that we should be picking up very early. And I liked your one that every day morning wake up and touch the toes and nose and understand whether there is any change. Thank you, John. That was a wonderful comment. So anybody have any question to John? We can have some 1-2 more minutes time. So John, what about the take of time? Say that we know that financial toxicity is a big toxicity. So if somebody asks me say at the end of 2 years, there's a complete remission. So can we accept that we wait till it comes back? What is your take? I know there is no good data on that.
So in the NHS in the UK, you have no say over that. It just stops. But in the private sector, in the outside of the NHS in the UK, so I have patients who've been on immunotherapy now, a couple who've been on it for 7 years, and they had widespread metastatic disease, and they remain in complete metabolic remission in the body and brain on their immunotherapy. And in fact, it's very hard to tell those patients, you know, let's stop, because to them, they see it as their lifeline. And they, as you can understand, they're really worried when you say, you know, we can stop and watch, because the data that has come out, albeit after 1 year stop with nivolumab, there was a certain number of patients who, when they had their drugs reinstigated on progression, it wasn't 100% response rate. There was a group of those patients who didn't respond once it was restarted. And when patients ask you to drill down into that level of detail, it kind of, as you may imagine, makes them not want to stop. But it becomes incredibly expensive.
Yep, that's the issue. So as you mentioned, so I think maybe we can think of some intermittent thing, as you said. I mean, there must be some solution, because this type of costly drug, say 7 years, I cannot make the calculation what is the cost in our country. So this is a challenge, and I think duration could be another issue. You know that the durvalumab now they are telling not 2 weekly, this 1400 fixed dose, 4 weekly they have given a approval. So this type of thing may make some change, hopefully. But end of the day, definitely it is a game changer, and it is going to make a big noise in the whole survival and the management of this. And I don't know, maybe when it will come along with other drug combination or radiotherapy, maybe the dose may come down. We don't know. I mean, as we see the combo is doing better, maybe the time will come like trastuzumab, once that Avastin, it was 15, then they came down. Like this type of drug, maybe the dose will come down. So thanks, John. Again, I am you for sacrificing your holiday, and now you will be sacrificing your holiday every Sunday, because we have moved the program again to Sunday. So we will be expecting you on next Sunday. The session will be on the role of EGFR in non-small cell lung cancer, and this time we are going to have a debate with our juniors. So hopefully you will join with us to share your thoughts on EGFR mutated lung cancer and also on the juniors debate. So if we have the result of the quiz, we can wrap up the session, because I was supposed to be finished by 1 hour. I think I am 1 hour, 15 minutes.
Before giving result, can I say something?
Yes, please.
One of our colleagues, Dr. Samia Muna, FCPS trainee of NSCLC, is COVID positive. I am requesting everyone to pray for her quick recovery.
Inshallah.
She is a regular participant in this platform.
Inshallah, we will be praying for her and tell her to seek for any type of support if she needs. We are always there. So now we have the result. The winner is Dr. Nosheen. She has scored 90. So the future user of immunotherapy, I can see Dr. Nosheen. Congratulations, Dr. Nosheen. So now I request our president, sir, to wrap up, finish the session, sir.
Thank you, Kamal. Heartfelt thanks to John Conivier. He has joined us and has taken part in our sessions. I'm really thankful to him. One question I couldn't understand is, Suman was telling what the role Ms. Jaffer played in this. They have in favor of the tumor or in favor of the patient?
Ms. Jaffer, sir. Sir, it was the concept of Salam, sir.
Okay, it might be. I thought you said in favor of tumor or in favor of the patient.
Ms. Jaffer was in favor of tumor against us, sir.
He stopped his tumors.
Yes.
Okay, thank you all very much. We had a nice session today. So we can meet again next Sunday possibly. But if days is becoming shorter, the time has to be shorter.
Yes, sir.
Have to make the time. Okay, fine. Thank you very much. Bye bye, everybody.
Thank you, sir. So we want to thank our partner Roche, who was the partner for this 10th session. So today is the last session of Roche sponsored program. We will have a new sponsor from next week. That will be AstraZeneca, and hopefully we will have a better session. More participation will be there due to the time change. I think there was a bit less number of participants today. Hopefully we will have a better participation tomorrow, next week, and we all will be praying for our colleague who has been recently diagnosed as a COVID positive. Inshallah, we expect she will recover and join us in the next week. Thank you very much. Thank you to all, to the presenter, to John and everybody, and thanks to all the participants. Thank you all. Goodbye.
Thank you.
Bye bye.
Assalamualaikum.
Thanks all.
কে আক্রান্ত আছে কোভিডে?
স্যার যে সামিয়া স্যার আমাদের একটা জুনিয়র মেয়ে স্যার, স্টুডেন্ট স্যার।
ভালো আছো নাকি?
জি স্যার, ভালো আছি স্যার।
ঠিক হয়ে যাবে।
ওকে স্যার, থ্যাংক ইউ স্যার। আসসালামু আলাইকুম।
জি স্যার, আসসালামু আলাইকুম স্যার।